Hello, mate, to Thrive Nation. It's all about regenerative medicine today, and that's something I've been doing for 15 years. So it's going to be an absolute privilege and pleasure to have a robust discussion with Dr. David Karli, MD, MBA, and a regenerative medicine specialist in Miami, Florida. He's a physician, he's an entrepreneur, and he's developed the Karli Center. But also, what I'm very interested about is the new technologies of gray ledge technologies and what he's doing with regards to the cellular therapies. It's a warm welcome to have you on, David.
Thank you, Steve. A pleasure to be here. Thank you for having me, and hello from across the world.
Yeah, it's a privilege. We can get together as prolotherapists and regenerative medicine specialists and talk about this because I think it's probably one of the most undervalued areas of medicine, according to me, and it just hasn't gained the traction that I think it should have. But maybe we can just start with this. What is regenerative medicine for people that are listening out there? We're in 159 countries now, but there's a lot of education that we have to really get out there so that people know their options when it comes to neuromusculoskeletal pain.
Yeah, I think a great place to start because there's a lot of confusion around that very term, regenerative medicine. So, in theory, regenerative medicine is a discipline of medicine where we're working towards regenerating the body from the inside out. Okay. Now, interestingly enough, most of the practice of regenerative medicine today in its current form doesn't actually regenerate that much. So we're a little ahead of ourselves in terms of our goal, which is to regenerate the body, which we can do with some capacities, limited capacities. However, we're moving towards that ultimate end goal. What we're typically doing in regenerative medicine, and that involves a lot of different things. Today, we're going to focus on one element of that, which is cellular therapies, which is near and dear to your and my heart. But we use living cells to try to stimulate management of disease and wherever possible, stimulate healing. Okay, now again, there are limitations to what we can do to stimulate healing and regeneration, but that is the goal. And that is what the cells are trying to drive. That's the process they're trying to drive when we apply them in our cases to orthopedic issues and orthopedic conditions.
Yeah, well said. And also, having a look at my success rate with patients, like about 90%, but that doesn't mean all 90% are regenerating. It's functional. They're getting functional results. They're getting, at least 80% in their pain reduction, which is really, really success for me. But we do see those that do want to retest and rescan where we see regeneration, especially in the knee. We've
Right,
seen that significantly, the meniscus regenerating.
right,
But
right.
then the typical MD around the corner, the orthopedic surgeon or the sports medicine doc says, listen, it's impossible to regenerate cartilage. What would you say to that with regard to, let's take the meniscus of the knee, because that is a common rebuttal that I get from patients and clients over there. Yeah, my doctor, my surgeon says you can't regenerate the cartilage.
Well, let's break it down a bit further. So the tissues that we deal with in orthopedic problems, degenerative processes, meniscus being one of them, have a common theme, and you know this, but for the audience, we'll reiterate. They're what we call avascular structures by and large, meaning they don't have a direct blood supply. Because they don't have a direct blood supply, their capacity for healing is ultimately limited. If you can't get blood to it, it can't really fix itself. Now, meniscus is an interesting one because the outside part of the meniscus does have a blood supply. The inside part of the meniscus where most tears occur does not. So that one's a little bit unique. But cartilage, discs in our spines, tendons, okay, ligaments by and large. These are all avascular structures with limited capacity to heal. And that's why the effect of living and aging is cumulative. It builds up because the tissues can't revert themselves back to normal, like your skin can, for example. We accumulate degenerative processes, and so many of us then end up living the second half of our lives with painful degenerative orthopedic issues. So if we look at meniscus, we apply the concept is, okay, well, if the tissue can't fix itself, in simplistic terms, then what's the reason for that? Well, blood can't get to it because it doesn't have blood supply. So in theory, just think about it. Couldn't we take the elements of blood that contribute to healing and apply them where they can't go? In the meniscus, in the disc, in the joint, cartilage, etc. In theory, it just makes perfect sense. It's incredibly simple. Now, the processes that are stimulated are immensely complex, but in a nutshell, what we're doing is giving it a temporary capacity to heal, to stabilize, to control inflammation, etc. Does that answer your question?
It does, and maybe you can, because you've been doing this for a while, and maybe you can just let me know, like a knee condition, we see a lot of degeneration there. Maybe give an example of an archetype or sort of an avatar. If someone comes in and supposedly bone and bone, you do an X-ray, MRI, there's still some meniscus, but you see that regenerating. So the person goes in for a scan 18 months, 24 months later, and we see regeneration of their tissue where some
Yeah.
people don't.
Yeah. Well, I think part of our ability to drive regeneration is when we get to the disease. It's definitely better if we can get to it earlier. But unfortunately, so many patients don't get to us until they're well into the disease process and more and more and more deterioration has occurred. So we talk about kind of two principles in regenerative medicine: healing augmentation in an acute injury, an acute meniscus tear that just happened. We can stimulate healing and repair in that situation. We're just helping the body along right after an injury. We're getting to it right away. That's more of a sports medicine type of application versus disease management, which is a chronic degenerative arthritis. The cartilage has collapsed, and as the femur and tibia collapse on itself, it jams the meniscus together. That meniscus deteriorates over time. Much harder to reverse. Much harder to reverse, because the things that are causing the deterioration in the first place, the root cause, are still going to be there, even if we're able to improve the health of the meniscus tissue. So it's a complicated, series of things that contribute to that process in the first place. The take-home message is, historically in regenerative medicine, we get people at the end of the disease. I think it would be wonderful to get them earlier in the beginning or mid stages of the disease, because we have a much greater potential to influence the course of that disease process, prevent it from getting degenerative in the first place. If you can prevent it from getting degenerative, then guess what? You don't have to regenerate it.
Exactly.
So this is a shift that's slowly happening, and some of it was driven by cost, right? Is it cost effective to intervene when someone has minimal symptoms? I always joke with patients that I can't do better than no symptoms. You're not going to feel different if you don't have a lot of symptoms. So we haven't historically been preventatively applying cell therapies as soon as we see a little meniscal tear, for example. But you could make the argument that that does make a lot of sense. We're seeing that transition slowly occurring. But what drives people to the doctor is what? Pain. Yeah. It's not the tear. If the tears, we see meniscal tears all the time, you know this, that are minimally symptomatic. People don't have a lot of pain. So yes, can we stimulate repair? Can we stimulate healing? To a degree. But if the cartilage is gone in a bone-to-bone situation like you just described, even if you regenerate the meniscus, the pressures that are resulting from the cartilage loss are going to just degenerate it once again. So it's a much bigger paradigm that we have to think about in an arthritis model, for example, to ultimately regenerate a knee joint, for example, back to normal.
But a lot of those ligaments, those stabilizing ligaments that actually degenerate as well, they lose their structure, they become looser. Then you get more movement, you get instability in the joint that causes more degeneration. If those ligaments are strengthened, I did a lot of prolotherapy, Jeffrey Patterson, Tom Raven in the days, the Hackett and Hemwell spent time in Mexico. So I've done the work there, and it looks like if we can get those ligaments, the steel in the building stronger, that can help to prevent further degeneration and help the regeneration, because now you're creating the steel in the building.
Of course. I mean, if you get destabilization of a joint, so ligaments basically keep joints stable and moving smoothly. If there's degeneration, you get translation of that joint that's abnormal, and that sets up wear and tear that leads to more and more progression of arthritis. So if we can stabilize instability, now instability can result from multiple things. It can be wear and tear over time. It can also be that volume loss. As cartilage is lost, the ligaments naturally will get looser, because the thing that was propping them up, the cartilage height, is gone. So it's like a rubber band. If you reduce the tension between two ends of a rubber band, it's going to get looser. Yeah. So it behaves similarly. So do we just tighten it up in a new normal of height of the joint? Potentially. That's the Prolo, that's the Prolo approach, which does have some merit and some sense. There's this functional unit concept that's become popular. Don't just treat the inflammation in the joint, for example, which is the primary driver of symptoms, but think about it more holistically. And it does have merit. It's just hard to study, because now we're doing 6 different things at once, and what ultimately produces the positive effect. From my world, we really think about we see our role as studying cellular dose and response, cause, put cells into the joint, and effect. This is the outcome that resulted. And if we do 6 things, now we have 6 variables to consider instead of 1. So it just makes it a little bit harder and more complex to weed through. But fortunately, with modern analytical advancements in machine learning and algorithmic learning, we're able to tackle much more complex data sets now and tease out of predictive value. Which are the values that allow me to predict success and failure? Those are the most important ones that we continue to chase.
Brilliant. Now, what would your success rate be with sort of cellular therapies in a knee and osteoarthritic knee across the board? Because I know people are going to be listening and saying, I've got osteoarthritis, should I do regenerative medicine?
Yeah.
What is my success rate? What is my risk rate?
Yeah.
What's happening at the Karli Clinic?
Yeah, well, we took that process on head on. And so, I want to talk today about cellular dosing because it's really what I'm known for. But we track every single patient that we treat in a database. Okay, we believe that's a standard of care, especially in a controversial field where there's a lot of misinformation and people are having trouble getting educated. So every single patient we treat is tracked. So the cellular dose we implant as part of their cellular therapy is tracked alongside with patient-reported outcomes, how the patient is doing at different points in time. And then we have, I believe, 5,300 treatments under study in our database at the moment. So we've accumulated a good bit of data that now allows us to answer that question that you just asked. Steve, if you come in with a grade 2 knee arthritis, we've treated 357 patients with that problem. When we apply this cell therapy, here's the exact results that we see. And by and large, with moderate to severe knee arthritis, we're seeing functional restoration, meaning return in function in the 80 and 90% range, holding at least at 18 months. That's our furthest data point. Now, we're going to continue to track those people because we know it can last longer than that. But that's a metric I can use to counsel a patient to help them make an informed and educated decision. Should I do this or not? On the subjective side, pain relief, we're seeing pain levels down below 2 out of 10, sometimes 1 out of 10. So that outperformed my expectations. Because as you know this, as doctors, we tend to think we're doing better than we really are until we actually start to track it. And then we get a little dose of reality to say, well, subjectively, you thought you were a hero, but it's not quite perfect. So I'll take that in orthopedics all day long, right? An 80+% functional restoration and a pain level of 2 or below as an average. That I would put that up against arthroscopy. I would put that up against knee replacement. I would put that up against anything. I'll take that all day long.
Sure. Well done to you. That's incredible. And well done for tracking the patients because that takes a lot of time, energy, and resources. So let's talk about, your success rate, especially the cellular dose and, looking at the technology you're developing because that is close to your heart. And you've obviously studied and seen that that's a very important variable. Tell us a little bit about Greyledge Technologies and why you developed it and, what you found now with regards to cellular dose.
Yeah, it's a long history. I started Greyledge Technologies in 2010. And it really was driven by, back in the early days of the field, not knowing what was in my syringe, right? And conceptually, what in medicine do we do where we don't understand a dose? We certainly wouldn't prescribe a medication without a dose, okay? There's very few things that we do where we're kind of flying blind. And I felt like it was, okay, let's use PRP as an example, simple example. Let's take some blood, let's concentrate it, put it back in. Well, we still know it's blood with blood components, but I don't know how many platelets were in the platelet-rich plasma, how many white blood cells were in there. So I felt that was an unacceptable and unsustainable approach. And we saw early trends towards success. That was great. It tended to work, but I had no way to predict who was going to succeed and who was going to fail. And it also didn't allow me to improve it at all. It was put it in there and let the magic happen. So we wanted to first solve the problem of let's figure out how to dose a biologic, PRP, bone marrow concentrate, micronized adipose tissue, the products that come from the patient's own cells, okay, which is in the United States what we're allowed to do legally. So we started down that process, and it has evolved over many years into, okay, we figured out how to measure. Okay, now let's figure out how to make that a validated measurement, meaning what we're measuring is actually accurate. There was a lot of work that went into that. So we could publish it, for example, and say it's an accurate measurement because it had never been done before at those concentrations, extremely high concentrations. Then we registered this company with the Food and Drug Administration on day one. We had to survive audits from the Food and Drug Administration, which we've done 3 times over the years. So we wanted to be very transparent about what we were doing. Then over time, we said, okay, we can measure. That's great. We can think about these products from a quality control standpoint. Now we need a system to collect those measurements and actually prove that dose matters and dose can be optimized. Okay, I treat a 65-year-old diabetic smoker differently from a 23-year-old athlete. I treat a rotator cuff tear different from a chronic degenerative knee arthritis. A one-size-fits-all solution seemed unrealistic for the field. So that's what GrayLedge does. It doses biologics. We have measured the billions of cells and platelets and so forth that are in these products before it goes into the patient. So we know and we can see we've made a product that we believe optimizes the potential for success based on what we know from research and our own internal information. And then we study that continually over and over and over again with every patient that we treat to try to identify responders, non-responders, make adjustments, increase the dose, change the composition to customize it to ultimately make patients have a better chance for a return on their health investment because these are expensive things to do. So anything that we can do to improve their chances, we believe is value for the patient consumer that is investigating these types of cell therapies.
So if you develop a product, are you talking about a centrifuge that gives you a concentration, and then you're talking about a volume as well that you've come up with for patients?
Yeah.
Or how is that product developed so that you can reproduce it?
Yeah, there was 2 phases to it, and we're transitioning from phase 1 to phase 2. Phase 1 was let's get control over the manufacturing process so we can target a dose. We can target a platelet dose. Now remember, concentration is not dose. Historically, we measured PRP as what's the concentration of platelets. But if you put 2 milliliters in versus 6 milliliters, it's a totally different dose. So we convert concentration to dose. What are the total number of platelets I put in that meniscus? What are the total number of white blood cells, et cetera, all of the different cells, stem cells, et cetera. So that was phase 1. And to do that, we had to manually process in a laboratory type of environment, which it didn't exist. We had to create that from scratch. So there was a lot of work. So we modeled it after a hospital laboratory in terms of operating procedures and quality control program and all the boring stuff that goes on behind the scenes that were necessary for us to make the same hamburger in Sacramento that we make in Austin, Texas, right? We needed to be able to duplicate the process and not have apples and oranges and pears comparison. So the first phase was to get control using manual methods, laboratory environment, very standardized conditions. Over time, the goal is to automate that process because it's very difficult to scale a laboratory all over the world. It's much easier to scale an automated next generation medical device. So what we're doing now is trying to take all of our processes in the laboratory and figure out how to automate them to perform at the same level as our laboratory. And then we believe instead of 5,300 patients in our database, we could have 53,000 patients in our database to learn more and much faster.
So is this happening in medical devices? Is it happening in the States already? I mean, I can't remember. The last time I was there just with COVID and then in the trained with the American Association of Orthopedic Medicine. But is this happening from bone marrow aspirate? And is it happening from a lipo aspirate perspective that they're devices, but it's not happening from a PRP? Or what's the angle there? Are they not PRP devices that get measurement? I mean, we do it just from a cost basis. We got the centrifuge and we do a certain volume, and that causes our dose exactly how much that is, just because it's cost prohibitive here. I mean,
Totally, cost was the issue. Cost was the issue. It's expensive to do this, and we had to try to create a model that was cost competitive to alternative systems, and that was not easy because there was a lot we were building in, from the data to the technicians that we have to train to do this, to all of the equipment, and then all of the regulatory processes. So that's why it took 15 years. in order to have a working model that we could duplicate in other parts of the country and world, which we've done. But yes, so blood-based products, platelet-rich plasma, and bone marrow concentrate, we process with a measurement prior to implantation. Over the past year, we actually have been working hard to create the same capacity for micronized fat tissue. No one had ever been able to measure the cells that were in a micronized fat. So for the audience, micronized fat is we can isolate stem cells from progenitor cells from fat tissue or bone marrow tissue, okay? And in fat, what we have to do is to break up the fat to kind of free up the stem cells, if you will, and then apply them to a knee or a tendon or a ligament or meniscus or whatever. But when you micronize the fat or disrupt it, resize it, it's really cluttered and messy. So it's hard to pick out the cells in that complicated mixture that we create. So what we had to do was figure out how to very rapidly digest the cells out of the fat tissue so we could measure them. So that was research and development that we did over the past year and a half. And we were able to get the digestion process and measurement process down to about 20 minutes, which is incredibly fast. So our goal was, well, we do all of these analytic measures of cellular dosing and blood-based products. We have to be able to do that in fat. Now, why go through all this brain damage? Because if you look at 10 different patients and you just process them through a device without measurement, you'll get 10 totally different final products. There was no way to create a standardized target. Okay, so we're studying what's an optimal target for a meniscal injury, for example. Well, if we identify an optimal target, we need to make that every single time, not get close, or, I call it throwing darts versus hand grenades, right? We can't get close. We have to be precise, accurate. We want to make sure the patient gets the greatest value. So we just finished a project and we continue to refine that process where we can measure the progenitor cells or stem cells in fat tissue, just like we can for blood. And we're slowly rolling that out as we refine and perfect that process. To my knowledge, the first time it's ever been done.
Wow. Brilliant. Well done. That's really pioneering. Now, if you look at the three, if you look at the PRP, the bone marrow concentrate, and what I call lipoaspirate, why do you call it micronized? Is it the same thing?
It's the same thing. So in the United States, there are some limitations to what we can and can't do to the product before we can put it into the patient. So we can only alter it minimally. Yes, we can't change it a lot. Okay, so lipoaspirate is a process where you harvest the tissue. Lipo is fat, so lipoaspirate is a harvested fat. We micronize it just to free up those, because the cells are trapped in the fat globules.
Oh, is that why you call it micronized? Okay.
So by micronizing it, by passing it through progressive filtration to make it smoother and smoother and smoother and smoother, we free up those cells that are caught in the fat tissue to apply them to the knee where they can exert their effect more freely without trying to do so from a trapped pocket of fat, which is surrounding it. Okay.
All right.
Does that make sense?
That makes sense. And do you combine exosomes, or maybe you can speak onto that sort of subject of exosomes or ozone or peptides, anything else that you found beneficial?
Yeah. Well, let's go through all of them. So cellular therapies are exosome therapies. When we put the PRP or the bone marrow concentrate, for example, into a tissue, they release exosomes. That's how they perform their function. We used to think that you put stem cells into a knee, they just become new cartilage. That has since been scientifically disproven, as you know. Now we know that these cells coordinate the process of inflammation reduction and to create an environment of healing and regeneration and repair. They do that by releasing exosomes. Exosomes are vehicles released by the cells containing the information to drive the healing process. So there's a separate discipline of regenerative medicine where they just isolate those exosomes. So artificially, they stimulate cells or platelets in a laboratory to release them, and then they just collect them and they put them in. There's one difference, and I'm critical of the exosome market for this reason. And I've talked to a lot of scientists that are working with exosomes. I don't feel yet like we have perfect control over the message in the bottle, so to speak. Can we control, because there's good exosomes, There's positive messages in exosomes.
Yeah.
There's negative Cancer cells release exosomes as an extreme example. Exosomes are how cells communicate with each other under normal circumstances. So until you can control the message in the exosome to say heal, regenerate, repair, meniscus, cartilage, ligament, whatever it is, then I think allowing the cells to read the environment and react accordingly with exosome packages that are customized to the environment they find themselves makes more sense than stimulating in a lab where we don't know what the message is and then throwing them in the joint as an alternative. Now, that's going to get better and better, I think, over time. But today, do we have perfect control that all of those exosomes we're putting in there from the laboratory are the right message? We do not.
Okay.
We do not. Therefore, we cannot predict from exosome vial to exosome vial to exosome vial that those messages are exactly the same. They may be totally different. If you get exosomes from two different patients, it may be a totally different message. So I think it's got immense potential as the signaling pathway to stimulate healing and repair. Do I think we're there today to the point where I'm using them? No. And in the United States, there isn't an exosome product that is licensed for the types of applications that we use them for. So it's still in the research and development phase. So incredible potential. Is it ready for prime time yet? No. Am I recommending it to the patients yet? No, because the cells do the same thing.
Okay.
And if you want more exosomes, increase your cell dose or increase your platelet dose in PRP. That's how we approach it anyway.
In terms of dose, I know obviously it's got to do with concentration and volume, but what type of volume are you using when it comes to the PRP generally on an average patient?
Yeah, so let's use knee as an example. So knee is a fairly large joint. It can hold a fairly significant volume. I mean, you don't want to blow a knee up like this when you inject anything into it. So a typical knee arthritis case, for example, will put about 5 to 6 milliliters or 5 to 6 cc's of volume in, which is a little vial of a syringe vial, something like that. Okay. Again, we don't want to blow up the balloon, so to speak, and stretch the joint capsule. That's very painful and uncomfortable. So we're playing around now. We talked a lot about dose, but now we're playing around with the concept of dose and concentration. So if you take the same dose in 6 milliliters and put that same dose in 2, same dose, different volume, does that impact outcome? Some people in the field believe that it does, i.e. a higher dose in a smaller volume is better than the same dose in a larger volume. Don't know the answer to that question yet, but a very interesting one to explore.
Okay.
So in a knee, we'll put about 5 to 6 milliliters. If there's a lot of fluid in the arthritic knee to begin with, which is often the case, these are swollen, inflamed knees, we want to take that fluid off first. We don't want to leave nasty inflammation, toxic environment in there. We want the cells to go in and get control. And the harder they have to work against a bad environment, the slower they tend to take effect.
Okay. And ozone and peptides, what's your experience there?
So ozone, no, although interesting, just because, again, part of my job is to study cause and effect. And the more variables I throw at things, the harder it is for me to determine what's an optimal dose. So we are a little purposefully focused on how we approach these things, with one exception, and that's the whole functional medicine pathway, right? So if we talk about hormone optimization, I'm very interested in studying hyperbaric oxygen therapy of our cells prior to implantation and then post-implantation. I think the data has come a long way for HBOT, and I think that's a really good one with some data that we should pursue. And we actually are putting in a hyperbaric system here at our center, and we're going to be studying that and tracking it as a variable. But the HBOT data has come a long way, and I've continued to monitor and track that. Things like peptides. I consider that part of the hormonal axis for some of the peptides. And if someone has a lousy hormonal axis, they have low thyroid, testosterone, estrogen in women, whatever might be the case, we feel very strongly, and there's some data to suggest, how could that not affect cellular function? It must affect cellular function. So should we fix that first before we would do a bone marrow stem cell treatment? You certainly can make the argument, okay? Now, how long do you have to fix it before it optimizes the cells? We don't know all of those things. But as a general rule, you talk a lot about biohacking on your show. right? Which is great. And I think it's a great movement because by and large, these are low risk interventions that have a lot of potential to help. But all of biohacking really is an effort to improve our cellular health. And anything that can improve our cellular health should translate into an improved capacity of our cells to
Mm,
help us
sure.
in a therapeutic capacity. So we're very interested in all those things, but we have to kind of slowly, pick and choose the ones that we think have the most merit. Peptides, as you know, are moving very fast. So it's hard to keep up with them because so many new ones are coming onto market. In orthopedics, the ones we tend to focus on are the natural growth hormone stimulators like Sermorelin, the BPC 157, TB 500. BPC 157 has more data at the moment. Both have theoretical merit. We're kind of monitoring those carefully. 15 years ago, you could give testosterone and growth hormone together, but the FDA changed their position on that, even though the data on that combination, when done properly, was very good. So now we have to kind of do workarounds and figure out other ways to stimulate, because insulin growth factor, growth hormone levels in the body decrease with time, just like testosterone does, or just like estrogen does. Yet we weren't fixing that part of the
Mm,
equation. So we're missing an important piece. Everything declines with age. We can try to stimulate the body's own production, but at some point the body just stops making it. So you can stimulate it all you want. If it's not going to make it anymore, now you're looking at a replacement type
mm,
situation. So that's an ongoing assessment that we have to continually reevaluate with patients. And I love this concept when it comes to functional medicine applications of the point of diminishing returns. When should we intervene? Let's use a guy for an example. When should we intervene with testosterone optimization? Mostly it's when the guy starts to get really symptomatic and feel terrible. By that point, his testosterone is usually pretty low.
yeah.
What about intervening when the guy's just starting to feel those symptoms? And the data suggests that the earlier intervention in the long-term health, from a longevity standpoint, is actually better. But we're not doing that as routinely, partly out of fear, which is misguided, that testosterone optimization is bad. The data does not support that. But we're talking about using it for much longer periods of time, starting it at 38, for example, instead of 47. That's an extra 10 years of
Mm,
exogenous testosterone. Does that have negative effects at 65 or 70 years of age? We don't have perfect answers to that, but the body of data is significant to suggest that medically monitored responsible testosterone optimization has by far
mm.
health beneficial effects with minimal risk.
The thing is, with patients, who's doing it medically, managing it correctly. That's the whole different thing that is
Sure.
such a problem. When you got the cellular therapies and the regenerative medicine, it's difficult for them to overdose or take testosterone too long or too much. I mean, a lot of the males that I see, and the research shows that 50% decrease in free testosterone over the last 30 years. I had Tracy Gappen on my show talk about testosterone incredibly,
Right.
but I mean, you look at that testosterone decrease, surely it has a significant impact on neuromuscular skeletal health.
For sure. How can it not? It
Yeah.
affects every other system in the body. How would it not? And even if you just look at the effects from an inflammation control standpoint, if we're degenerative, right, we have the effects of aging on our orthopedic systems, that's going to produce a fair amount of inflammation. And we know that testosterone, well managed testosterone supplementation, is very effective at controlling inflammation.
Mm,
Part of that is due to reduction in body fat and improved lean body mass, muscle mass, but also kind of more of a direct effect. So whether it's direct or indirect doesn't matter. The point to your original question is that functional medicine approaches, well, functional medicine and regenerative medicine are converging. They're going to intersect. And I
mm,
think that's a fantastic thing because they're perfectly synergistic. And we are continuing to explore how to piece those elements together to produce the better whole. There aren't perfect answers to that, but I think if you do functional medicine well, it's going to help you do regenerative medicine well as
mm.
also.
So someone's listening out there and they've maybe struggled with PRP or prolotherapy or ozone, but the physician didn't look at, functional medicine and look at their hormonal health or DHEA or vitamin D status. Do you think it's worth are there patients, maybe reframe this, are there patients that didn't do well with cellular therapies and then you started looking at them systematically and saying, listen, you know what, we need to look at your hormonal health. And when you did that and the cellular therapies, they got better.
Hard to track, but yes, without a lot of firm data to support that. Anecdotally, yes. But I get a lot of patients in second and third opinions who have gone to other countries and gone all over the place and failed cell therapies, whether it was PRP or otherwise, or even allogenic cell therapies in other countries. And I ask them two questions. Your point is a good one, but before I ask them that, I said, did your physician know the dose? And 99.9% of the time is no. Then I say, how do I know you failed it if I don't know what dose you got? How do I know it was a suboptimal dose? You just didn't get enough of whatever it is that you got. And that's why you didn't succeed with therapy. It's the only way really to determine if it worked or didn't work was to also understand what you got. So the first question I ask patients if they come to me and say, you know, I tried PRP, it failed. I said, well, did your doctor know the dose? No, they didn't. Then I don't know you failed.
Yeah.
So it becomes a huge problem that we're trying to drive. And I've been saying this from podiums at academic conferences for 12, 15 years. We have to get some quality control into this business, or it's just a roll of the dice. And if you have PRP and you have a positive response, that's wonderful. You're happy. That's great. If you didn't, was it because the PRP truly didn't work? And it doesn't work 100% of the time, or stem cell, whatever it was. Or was it that you got a suboptimal dose of it? In which case you wasted a whole bunch of money, right? Very difficult problem for me, because now this patient has spent sometimes, especially with offshore models, $20, $30, $40,000 on these types of things, coming back not better and asking me if they should do more.
Yeah.
So I'm in a really difficult position, because obviously, we've worked extremely hard, and I counsel patients almost painfully, honestly, when it comes to whether they should or shouldn't. I tell you, here's what we know from research. Here's what we know from our own internal data. Here's what we don't know. Okay. And we weigh that versus their alternatives, and then use that information to try to gauge whether they should or shouldn't do these types of therapies. Sometimes it's not the best thing to do. But by and large, most patients that are seeking this out are looking to avoid surgery or just manage a problem better, or they failed everything else, and this is kind of their last ditch effort. So it's a really huge problem. On the hormonal part, more and more so we're thinking in the direction that you just mentioned. Let's not just get tunnel vision on the arthritic knee or meniscal tear, but let's use that as an opportunity to try to capture more general health as well from a functional med perspective, including the hormonal axis. Yes.
Especially the hormones, because I mean, they're just so critical for repair. We see what happens with testosterone, with muscle size, strength. I mean, it's obviously having a huge effect on the neuromuscular skeletal system, but maybe let's talk about the actual testosterone receptors with regards to joints. I know from my previous days of medical school, estrogen receptors are quite crucial at sort of a joint level. What about testosterone? Because I mean, the data is 50% of women's testosterone, free testosterone in the last 34 years. I mean, you're talking about a significant problem. So, and that's why I've spent a lot of time with my patients, how to improve it, how to delay it, how to optimize it, what are the benefits. Costs becomes a massive, massive issue, especially here in Africa. But let's talk about those receptors from a joint perspective, how important testosterone is.
I don't know of a lot of direct data to answer that question. There are testosterone receptors everywhere in the body, as there are for every other hormone that's floating around. So I can't imagine it doesn't have an effect. When we put guys on testosterone or we optimize their testosterone, their joints tend to feel better, right? They just, not only do they get more energy, but their inflammation comes down, and they kind of it's the match that lights the fire. They kind of just get that vitality back. They're able to push harder in their fitness and so forth. So I don't know if I can answer your question perfectly from a receptor standpoint, but I will say this: one thing that is interesting is this concept of intracrinology. We all have testosterone receptors. That doesn't mean they all behave exactly the same. That's why one guy might be optimized at one testosterone level, and another guy might need 30% less and feel just as good. So the hormone optimization game is a little bit of trial and error. We're not just tracking a number necessarily. We're tracking the number in combination with the response to the treatment. So the way your cells and your cell receptors react to testosterone, whether it's your own natural testosterone or something we're replacing in an older individual, it's not the same. And this is what's driving us to the next phase of this, which is in line with the whole functional precision medicine approach, which is to get down to the genomics level and start to understand those things. We just submitted an NIH grant that's under review, which is going to look at 200 knee arthritis patients with bone marrow concentrate, where we'll do all of our cellular measurements. We're also going to study subpopulations of progenitor cells. They're not one cell type. There's many different types. And then we're going to do a whole genome sequence and measure an epigenomic analysis on those patients as well to determine how their genome and epigenomic environment. And for the listeners, epigenome is what influences gene expression in your DNA. That's modifiable, by the way, modifiable partly by hormone correction, right?
Yeah.
It improves the epigenome, microbiomics, et cetera, all of these things. So we're going to consider your DNA and the environment that your DNA is operating in as a variable that could contribute to success and failure, or may cause us to change our protocol for how we treat you, this customized precision medicine pathway. So it's kind of weird to think, wait a minute, there's a funny story. Years ago, back in the early days of PRP, I was treating a very famous television producer. This is back when I was in Vail, Colorado. And he came in and he had knee arthritis and he was investigating PRP. And I went through my spiel with him and he said, Dave, let me get this straight. You're going to take some of my blood. You're going to go spin it in that little gizmo over there. You're going to come back. You're going to re-inject it into me and you're going to charge me money for it. I said, yes, sir. He said, you're a genius.
Incredible. Yeah,
But
no.
this concept that we can take your cells and actually improve how they work for you is a little bit, it's almost too good to be true. It sounds too good to be true. But back to the biohacking issue, I mean, look at the biohacking movement and how that's really controlled the airwaves. We spend so much time trying to improve our cellular health. And then what do? We go and take someone else's cells and implant them into our body. Why would we do that when there's no direct data to suggest that someone else's cells, or even birthing tissue cells for that matter, are any better therapeutically than yours? Now, it's a very interesting science, and there's a lot of research going on there, and I think there will be applications. But today, if you're in reasonably good health and you spend thousands of dollars on your biohacking protocols and functional medicine protocols, why wouldn't you use your own cells? You're doing the work to make them better. Let's put them to work for you and take them where they can't go and allow them to do their job.
Sounds good. So you've spoken about HBOT, hyperbaric, incorporating that into your practice, possibly with all your regenerative medicine techniques. What about red light therapy? I've been trying to encourage patients to use it on a daily basis. We just use a product called the Flex Beam. We've got infrared saunas, red light saunas as well. A company called Sauna Space, actually from the US, we found extremely good. What is your sort of feedback on combining red light therapy with regenerative medicine?
I'm hoping it's effective. I don't have the data to support it yet because it's very hard to study. The improving ATP production in mitochondria, for example, is hard to measure cost effectively. It's possible, but I mean, it takes millions and millions of dollars. So it's not something we can routinely do. The premise behind it conceptually makes sense. There's also the possibility of combining it with HBOT, where you would do red light in the chamber during your dive. In the newer systems that aren't fully compressed oxygen in the entire environment, you're taking it via face mask. We can actually do that. So we're curious about that. What surface area, what dose, what wattage, how many spectra of the light, in terms of the analysis, do we need to optimize? We don't know answers to any of these questions, so we're kind of throwing everything at it. Our nature is to take a systematic approach. Okay, if we're going to apply red light, I want to know how much power, what duration, what wavelength were applied, etc. I need dosing for red light. If I have dosing, then I can study it as a variable. Did it help, cause, and effect?
Yeah.
So my answer to your question is, it makes sense. I have more data on HBOT, for example, than I do on red light as it applies to regenerative medicine. And I think we'll go there. But in terms of, can I say for certain that it makes a difference? Not yet. I hope so. I'm optimistic. I hope so.
Now, let me ask you a question. Do you use red light therapy?
We use red light therapy with laser in an MLS laser situation, and we actually apply that. So we'll do a bone marrow concentrate, for example, or a PRP into a joint, and we'll hit that with red light and laser, which is a little different than a red light bed, for example, because it has the laser piece. Goal is one and the same, but it's localized to the treatment area, not the entire body. So yes, we do on a more limited basis. But again, the question is, does it matter if we just do it to the knee? The thought there is to activate the cells that we just put in.
Yes.
Versus treating the entire body.
Sure.
Or both.
Yeah.
We don't know the answer to that, but that's something we've been doing probably for about a year and a half, and I don't have enough data to clearly say that it makes sense. We don't charge people for that, by the way. That's just kind of an add-on that we do as part of their therapy. And it's just intuitive that it seems to make some sense, and we're following the field trend that people are liking that. There is data on laser and red light therapy alone for chronic itises and things that has merit. So again, I think all of these things probably will pan out to be useful. How useful is unclear. But the nice thing is there's no downside. There's no risk. It's not going to harm you. So if you want to do red light, hey, go nuts. Have at it. Wonderful. There's no risk. So I'm for it.
So in the last 18 months, with the numbers you got, you can't actually say now that you're using the laser, it's different to the previous years and the numbers without the laser.
Well, we got to track those people for a long time. So, 5,300 patients were over the course. So some of them are a day out, right? Some of them are 18 months out. So it takes a while for that data to come in, and we have to track them for a long time. And then we have to compare that to our old data without it. So it just takes a long time, and not every center that we work with is using that protocol. Another thing that we've started to do empirically is have people spin on a bike lightly for about 10 minutes prior to drawing their blood for PRP or bone marrow. We believe, and we're tracking some cell counts when doing that, and there's a trend, a suggestion that it may bump our cell counts a little bit just by we get the blood flowing, right? So it's something we've added to our protocol that, again, I can't say has panned out in terms of a definitive effect, but empirically makes no sense. It takes 10 minutes. There's no cost. Why not?
Yeah,
right.
That's interesting. And the HBOT, would you do it before or after or both?
Well, think about what HBOT is doing, right? We're hyperoxygenating the blood beyond what the red blood cells' capacity to carry it is. So we're pushing oxygen molecules directly into the blood. Normally, it's carried by red blood cells. So we're saturating 100% of the red blood cells with oxygen and then adding more. And the oxygen can diffuse into tissues without needing to be detached from the red blood cell in order to do so. That's how HBOT works. So if we remember, the orthopedic tissues have no blood supply. What do they also lack? Oxygen. Blood can't carry oxygen to the tissues, therefore they need oxygen. So it's a theoretical way to diffuse oxygen right into those tissues without relying on blood. So if we're going to hyperoxygenate the blood, then anything that can kind of get it moving would seem to be logical before. But that's just empiric, not.
But that's exactly what I'm saying. Is you're probably going to get a better quality dose out, but then you're also going to get oxygen if you do it afterwards, getting into the joint. So
before and after probably is the best answer to the question.
You probably could measure that. You could see, although how you're determining quality, you might be determining dose, but you can't determine quality.
Well, but think about it. So now, we've talked about induction of light to moderate exercise. We've talked about red light. We've talked about HBOT. We've talked about peptides, and we've talked about, now we're talking about 6 things on top of the cell dose that we just did. I got to figure out which of those things actually produce the effect.
Yeah, got you.
So it becomes a data problem. We can collect the data as long as we can measure it. But this is where we need artificial intelligence. There's no way we could scour that level of complexity in a database to try to tease out trends, not only of variables in isolation, one variable at a time, but in combinations and ratios. And it becomes incredibly complex, but we now have the capacity to tackle much larger data problems through these modern analytical tools, which we're actively applying.
No, and we need people
You
like
have to. We have to.
you have to.
You have to be in a. Yeah, you have to.
You have to get the variable, otherwise there's too many variables. So we do need people like you to do it. As laborious
Yeah.
as it is, you're a pioneer in the field. So very grateful
Yeah.
for that. Maybe you want to comment. I know we've got a few minutes left. I've been 26 years in practice here, and I've just never seen ligament laxity and joint hypermobility syndrome and Ehlers-Danlos syndrome to this degree. I'm shocked. I'm totally shocked. What is happening to joint integrity and instability? Number one, what do you think your reasons are? I mean, it's starting young. I mean, I'm seeing children now with instability at a very young age. What do you think the primary causes are coming from this joint instability and joint hypermobility syndrome?
Well, historically, that was a genetic problem. Historically, right? Ehlers-Danlos is a genetic. You have genes that give you loose ligaments. Now, some people are just looser than others, especially women. We see that estrogen can induce those effects to some degree. Women, when they have babies, their ligaments loosen to allow passage of the baby in labor and delivery. So these soft tissues are reactive to different stimuli. Otherwise, those things I just talked about would never happen, whether it's hormonal or inflammatory, whatever. So if we're seeing an increase in prevalence of hyperlaxity situations, there's a probable explanation that's beyond genetic, because it's not like genetically it's increasing in the population. That would be unlikely. So there's some other variable that's contributing to it. Now, outside of a degenerative process where the laxity is due to the degeneration that's occurring, I don't know. I can't say that I have noted an increase in general laxity. I mean, we see our lax patients that come in, more females than men. So I'm not observing that same trend. So I haven't given it much thought in terms of answering the question directly. However, if I had to take a guess, a wild guess, first time thinking about this, I think the first place to look would be hormonal. It'd be the first place to look. If indeed hormone levels are declining, which is leading to a reduction in fertility, which is leading to a reduction in birthing levels and all of the things that we're hearing about from a public health perspective, then if those tissues are hormone responsive, it would be a possible explanation. But that's just my knee-jerk reaction to it. Toxins and phytochemicals and all of the other things that we're hearing. By the way, do you think in the 70s we drank out of plastic and ate out of plastic? Do you think that the plastics were better in the 70s than they are now? Is it that phytochemicals are truly causing the problem, or is it just that we're just starting to notice? I don't know the answer to that question.
Oh, we just can't detox. We can't detox like we used to, and we're not detoxing. So we same dose of chemicals and toxins, but we just can't get rid of them to the same degree.
Right. Well, here in the U.S., I mean, the food, the nutrient density in food is under attack appropriately, so as it should be, with the administration change that we just saw. And I think that's a fantastic thing, because the whole boom of the supplement industry is in part driven by the lack of the ability to get the nutrients we need from our diets, even if you're tight, even if you're clean.
Exactly.
So I'm a pro supplement guy, because again, supplementation isn't necessary. I hear these notions that we should base your supplementation on your genome. Well, that's just treating malnutrition. That's not optimizing supplementation protocols. The purpose of supplementation is to supplement to optimize micronutrients and macronutrients and so forth. So I view it a little bit differently. I don't know that that's a customization protocol. If we should have B vitamins flowing through the system because it reduces your chance of heart disease by reducing your homocysteine levels, then take B vitamins. Don't base it on your genome, whether you can methylate it or not. Right? Just take them. Okay, it's good for you and it's low cost. So it's really hard when you talk about these public health issues that are affecting things globally to tease those out. It's possible, but very difficult. So what I tend to do is keep things simple and focus on the elements we can control. Tighten your nutrition. Get exercise to the stimulus and intensity level that's going to actually change your body. Supplement with effective, high-quality supplements. Look at your biomarkers. Correct where necessary. Yes, pay attention to your gut. I think we're still learning on the microbiome, but it's come a long way. And there's no question it has an impact. No question.
Yeah.
But that's still primarily driven by diet more than taking probiotic.
Yeah.
The food you eat really dictates what's in your gut more than anything. So stress reduction, the pace of life, being in front of a computer, blue light, all those things, it's pretty hard to control, but focus on general health. When we are in a conundrum with a patient where we can't really figure out what's going on, sometimes we'll say, all right, we lack a diagnosis. That's a bad place to be. However, what we can do is focus on general health. Yeah. Let's tighten up the things that make sense. Sometimes that works, sometimes it doesn't, but it's always an opportunity to tighten up those pathways that are easy to control just with habit and discipline.
Yeah, well said. I think that's fundamentally important for people listening. If you've got a chronic condition or you've got a sports injury or you're in pain, you need to tighten those things up to maximize and optimize your healing ability when you get these treatments. Maybe just give a message of hope as we come to the end of the show. I mean, movement is life. The only difference between someone who's dead and alive is movement. So 100%. I think it's crucially important. And maybe you from a medical perspective and from a regenerative perspective is just give a message of hope in terms of how important movement is. And secondly, that there is regenerative medicines experts out there that can help you.
Without a doubt, I agree 100%. Even in an arthritis situation, we need to continue to move that joint. When you shut them down, they do worse. It's beyond question, and anyone who says differently, I would have issue with. It's the symptom problem that we have to manage, okay? And we do that more and more effectively every day. Cell therapies have outperformed my expectations when I started this a long time ago. Now, we still have to get better. There's a long way to go. We're not regenerating things back to normal inside the body. That's the ultimate goal, but we're getting better. And companies that are willing to take the time and do the painstaking work to try to advance that in a scientific, logical way are going to continue to advance this. Now with AI, the potential to accelerate it is greater than ever. The scientific process with randomized controlled trials with 25 patients influencing our medical decision-making, I would rather learn from 10,000 patients in a prospective registry than 25 randomized controlled trial patients. That's my personal opinion. Not that that's not important, but the big data sets, collecting data, observing trends with large numbers, I think is our immediate future to tease out how to take these massively hopeful elements of functional longevity, precision medicine, and regenerative medicine, combine them together. And I think you see the next great advancement in how we approach disease when that intersection occurs and we figure out how to manage it best.
Sure. Well said. And just want to declare favor and blessing over you, Dr. David Karli. You're doing incredible work and looking at variables that are very important without combining everything so that we've got some type of idea on dose. And I think that's fundamentally important. Hopefully we can shake hands one day when I come to Florida. It's been a while, but thank you for your time. Thank you for your expertise.
Yeah. Please do. And thank you for having me, Steve. Great discussion. And I applaud you on your work as well. And also the work on the podcast, bringing to light a lot of these important issues, which people need to know and have a trustworthy resource for.